Welcome to our presentation, Telemedicine Liability Considerations. This program is one in a series of educational videos produced by the Tennessee Medical Association, TMA, covering various aspects of telemedicine. This module is presented as a collaboration between TMA and SDMIC and will cover liability considerations focusing on changes during the 2020 coronavirus pandemic. Before we get started, I draw your attention to the disclaimer and disclosure to learners slide currently on the screen. It simply states there is no commercial support for this program, and our speakers have no financial relationships to disclose in connection to the material presented. Our speakers will introduce themselves now.
Thank you. My name is Julie Loomis, and I'm Assistant Vice President of Risk Education, Programming and Development with SBMIC, and I've been with the company for 14 years.
My name is Jay Baugh. I am a Senior Claims Attorney, and I have been with SBMIC for the last 20 years.
And I am Katie Smith. I am also a Senior Claims Attorney in the Claims Department at SBMIC. And like Julie, I've been with the company for 14 years.
Thank you to those attending this course, which is being recorded May 1st, 2020, in the middle of the COVID-19 pandemic. We understand physicians have been thrust into this environment and are looking for ways to connect with and provide care for your patients. Telemedicine is certainly a solution, and it has been widely accepted and promoted by the federal and state governments, CMS, and other payers. Please know that we are here to try and give you our best analysis and recommendations, but since this is an unprecedented time, we encourage you to contact other authorities for guidance as well. We know one thing for sure: you are essential. What you do is essential, and we are grateful for your interest in exploring alternate means of providing care for your patients. As we have seen in our business, the current COVID-19 pandemic has caused a sudden surge in telemedicine. Telemedicine may be the optimal means for providing care and limiting patients coming into the medical office in order to reduce infectious exposure among patients and healthcare workers. Physicians may be able to deliver at least some level of high quality care while greatly limiting travel and exposure and permitting uninterrupted care of established patients. Telemedicine is also a valuable way to introduce new patients into the practice. Today, we will cover some common liability considerations in the context of telemedicine. There are some unique risks to delivering telemedicine care that will be addressed as well. During COVID-19, there have been a lot of efforts made across the country to increase our nation's healthcare capacity, and telemedicine is at the forefront of that effort. I heard a study yesterday where there was a 2,000 increase in telemedicine just in the month of March alone. We are in an environment that is not only a test for our nation's healthcare system, but I believe a test for telemedicine. Hopefully this will be telemedicine's shining moment and perhaps fundamentally change the way healthcare is delivered in the future. Today, we will talk about each of the potential liability issues you see on your screen right now. Those are assessment of appropriateness of telemedicine, communication, which of course it includes consent, treatment and scope of practice, which will also include some comments about standard of care, documentation, follow-up instructions, maintaining medical records, and technical considerations. Next, we will hear from Katie about the elements of negligence.
It's important to understand that the law applicable to claims concerning telemedicine care is the same as the law applied to traditionally provided care. When we're talking about liability, what we're really asking is, was the care at issue negligent? To evaluate that, we look at the elements of negligence. First, duty. That's the duty that is owed by the physician to the patient. Second is breach, which is a breach of that duty. Third and fourth are cause, both causation and proximate or legal cause. And finally, damages, which resulted to the patient.
So Katie's talked about negligence in sort of a general way. Let's talk about it in a little bit more of a narrow focus, and that would be to look at negligence as it applies to medical malpractice cases in the state of Tennessee. You'll notice on your slide that there is a statute, TCA 29-26-115, and you'll notice that it begins with the phrase healthcare liability action. A few years ago, the legislature did away with medical malpractice cases in the state of Tennessee, and the way they did that was they took out the phrase medical malpractice case in the statutes in Tennessee and replaced it with healthcare liability action. So when you see that phrase, healthcare liability action, that's what we're talking about, is medical malpractice cases. And so in these type of cases, the claimant has a burden of proving the following three elements. And the first of those is they have to prove the recognized standard of acceptable professional practice in the profession and in the specialty thereof, if any, that the defendant practices in the community in which the defendant practices or in a similar community at the time the alleged injury or wrongful action occurred. Now, that's a very wordy type of sentence there, but let's break it down in just a couple of ways. And one is that the plaintiff has to show what the standard of care is for the community in which the defendant practices or in a similar community. Now, there are some states that look at what's called a national standard of care, and that is that all doctors of a particular specialty will practice the same way in every community in the nation. And that's not the way it works in Tennessee. In Tennessee, it has to be specific to the community in which the defendant is practicing. And that's going to be important later on in this presentation when we talk about standard of care as it relates to telemedicine. So what is the standard of care in which the defendant is practicing or in a similar community in which the defendant is practicing? And it also has to be at the time the alleged injury or wrongful action occurred. Sometimes malpractice cases can take several years to develop, and sometimes the standard of care changes over that period of time. But what the plaintiff has to show is what the standard of care was in the community in which the defendant practiced or a similar community at the time in which the alleged injury or wrongful action occurred. Now, when you think about standard of care, I think it's important to remember that there are at times different modes of treating a patient that would all be within the standard of care. I once heard a defense attorney refer to the standard of care as looking more like a box. And inside that box, there are different modes of treatment that could be within the standard of care. For example, you might have a case in which one doctor would treat a patient with medicine, another doctor would treat a patient with physical therapy, and another doctor would treat a patient with surgery. And just because they're different, that doesn't mean that only one is within the standard of care and the others are below the standard of care. It means that within that box, there are different ways in which the patient can be treated, and they can all be within the standard of care. So it's best to think about whether the doctor is practicing outside the standard of care rather than falling below the standard of care. In other words, it's a box rather than a line. And so that takes us to the second phrase, which is that the defendant acted with less than or failed to act with ordinary and reasonable care in accordance with such standards. So the first element here defines what the box is. What are the modes of treatment that are within that box, within the standard of care? The second element is, did the defendant practice medicine that's outside that box? We often talk about thinking outside the box, but that's not what you want to do as far as this particular statute goes. You want to show that the doctor practiced within the box, that is within the standard of care. And then the last element has to do with causation. As a proximate result of the defendant's negligent act or omission, the plaintiff suffered injuries which would not otherwise have occurred. So it's not enough for the claimant to show that the doctor practiced outside the standard of care. The plaintiff also has to show that the plaintiff suffered damages as a result of that. In other words, it was caused by the negligence or by practicing outside of the standard of care. And where that comes into account in a lot of cases has to do with a delay in diagnosing cancer. That's sort of the traditional way in which we see this causation element come into play. And the way that sometimes works is if a film's taken today and it's read as negative, and then a film's taken sometime later and it's read as showing a mass, and then someone goes back and looks at the original film and says, oh, well, this mass should have been caught in this original film, then that person might say the doctor practiced outside the standard of care. But if the plaintiff's percentage of successful treatment is the same, the survival rate is the same, if the method of treating the patient is the same, in other words, if there's no difference in the outcome for the patient, then the element of proving causation has failed. The plaintiff may show that the doctor practiced outside the standard of care, but they were not able to show the causation element that's required. So the plaintiff has to show both, that there was a practice outside the standard of care and that deviation caused the injuries that the plaintiff is complaining of. And obviously after that, it's not mentioned here in the specific statute, but then the plaintiff would have to prove damages. How much is it worth? And so those are the elements of negligence as it comes to, and so those are the elements of negligence as it relates to a medical malpractice case in the state of Tennessee. And so our next slide has to do with the physician-patient relationship.
And so thinking about the physician-patient relationship specifically in the context of telemedicine care, it raises a lot of kind of interesting questions. First, when are you in a physician-patient relationship? How long into a telemedicine encounter does it take for that physician-patient relationship to attach? As Julie mentioned earlier, you can have an initial physician-patient contact through telemedicine. You don't have to have a pre-existing relationship with the patient, and that creates a duty that's going to be owed to your new patient. The physician-patient relationship is generally created when you have mutual consent to the care between the physician and the patient, and the communication and the consent can be expressed or implied. Traditionally, when we think of telemedicine, we might think of the programs, the portals that patients can click on and enter into and provide some information and be connected to our physicians virtually. That's certainly a traditional way for that relationship to begin. And so thinking about that, you wonder what duty do you owe? Do you owe a duty just with the receipt of information about the patient? Do you have a physician-patient relationship only once you initially meet the patient? And if so, what duties do you owe them? What care must you provide? What opinion or recommendations must you provide? Or is it further into the encounter when there's more of an exchange about the complaints and the symptoms and the evaluation occurs? And honestly, there's no black and white rule for that. It's like basically everything else in the law, it is going to be case by case determinative. And this third point, I think, is a good one. It's always good to be cautious and to be reminded that telemedicine visits can be impersonal, can be informal. It doesn't have to necessarily come through the portal. It can be the cocktail party type of encounter where you have a FaceTime call from a neighbor or a family member, perhaps, with complaints. And so a question arises, is that a doctor-patient relationship? Has that been established? As the provider, as the physician, do you owe some obligations to the patient? But primary with creating the physician-patient relationship is going to be the consent of the patient. And Julie's going to talk further about that.
Thank you, Katie. Yes, providers must obtain the patient's consent for treatment. Obviously, that's the same as a face-to-face visit. What we recommend is that practices develop a specific telemedicine-informed consent form for their practice. Obviously, given the remote nature of the visit, it's sometimes difficult to get that written form in front of the patient, but in many virtual platforms, there is that capability. And if it's possible to use telemedicine in your EHR, your own electronic health record, there may be a component for telemedicine. We encourage you to explore that, and that would be a great place for you to obtain written consent if possible as well. But we absolutely realize that during COVID-19, verbal consent may be the only option, and it certainly is sufficient under the circumstances and in most jurisdictions and states, and in Tennessee. We will detail the verbal consent in a moment, but consider creating macros to ensure documentation of patient consent. Ensure that discussion of confidentiality barriers and documentation of the time spent in the visit. That's one thing I'm sure you have heard in a billing component of this CME activity, is that in billing, sometimes the time spent is what you use to determine what your level of service was for the virtual visit. One thing you might want to do is create a laminated card or something so that your telemedicine consent is always the same and you have that outlined very clearly. You don't have to have anything long. It can be simple, but you just do want to address certain elements, which Jay will go over in a minute. One thing I will note here is by confidentiality barriers, we mean you should consider these are unique, often unique risks to a virtual telemedicine encounter. So these are things such as patients who may allow others in the room with them, or they're within earshot, or they may be audio or video recording this encounter. So if you are okay with that, then you want to at least address that in your consent. If you're not okay with that, you might consider telling the patient that you're not recording the visit, if in fact you're not, and that you do not consent to the patient recording this visit for a number of reasons. There is no guarantee that the patient will abide by the terms, but it may provide some legal argument if there's a recording despite a mutual agreement to not record the visit. Since this is the transmission of protected health information, the dissemination of the medical information needs to be limited to the agreement of the parties, which could include a prohibition against recording. So following that, I'll hand it over to Jay to discuss more about the verbal consent.
So traditionally, physicians have been able to obtain written consent from a patient, but that's obviously not going to be a possibility when it comes to telemedicine, especially if it's a new patient. And so we have a slide here in which you have some considerations for verbal consent. And these are pretty specific, and these are specific to Tennessee, things that are required to get verbal consent for a telemedicine encounter. The physician must disclose the name, the current and primary practice location, the medical degree, and the recognized specialty area, if there is one. You're also required to ask the patient to disclose his or her current location. And that's really important when it comes to trying to determine whether the patient is located in a different place than you are, especially if the patient is in a different state. And we'll talk about that as we go a little bit deeper into the webinar, but that's very important that you ask the patient to disclose his or her current location. If you're treating new patients via telemedicine, then the consent should also include a general consent for treatment, which is something you would be able to obtain with established patients. But if it's a new patient, then you would want to be able to get a general consent for treatment as well. The physician should disclose that a telemedicine encounter has benefits of improved access to medical care by allowing you to remain at your home to access care. There are some unique risks to receiving care via telemedicine, such as I may not be able to completely assess your condition given the diagnostic limitations, namely the inability to touch or smell. There may be limitations in the equipment, security, or connection, which may render the visit inadequate for treatment or may result in a breach of privacy. If I'm unable to adequately assess you, then I will refer you for in-person treatment. Again, these are steps in verbal consent that are required in Tennessee for a telemedicine encounter. And then after you've made those statements to begin with, then you might ask some of these following questions, or actually you should ask all of these questions and maybe some more that we'll talk about in just a moment. Do you understand the benefits and risks of telemedicine? Do you have any questions before we proceed? And do you wish to continue with this telemedicine visit? You would want to ask all of those questions, and then depending on the specialty that you practice, you may want to ask additional questions. And you may want to contact the society for your particular specialty in order to get some information for questions that you would want to ask in addition to these questions for a verbal consent for a telemedicine encounter.
So although it's not anticipated that you would need to have a specific informed consent for a procedure or anything like that, obviously via virtual medicine, but you may be required to give the patient enough information to make an intelligent decision about whether to undergo a particular treatment that you may be referring the patient to, or that you are asking the patient to undergo in order to have a complete and more valuable examination. And it may be even a medication that you plan to start with the patient that needs follow-up or monitoring or serial testing, something that would require a heightened level of understanding and acceptance before undergoing that treatment as well. So for what it's worth, we thought that it would be valuable to show you in Tennessee what the jury would see in determining what informed consent measures, whether they have been taken appropriately or not. So in this slide, I'm just going to read it. A physician has a duty to give a patient certain information before treating the patient. The information the physician must disclose is that information about the treatment involved and its attendant risks to enable the patient to make an intelligent decision about whether to undergo the treatment. And the next slide will tell us a little bit more about the rest of the informed consent, and that is in determining how a reasonable patient would have acted under the circumstances. You, the jury, should consider the testimony of the plaintiff, which is the patient, the plaintiff's idiosyncrasies, fears, age, medical condition, and religious beliefs, the presence or absence of alternative procedures, treatments, and the potential risks and benefits thereof, and the impact of no treatment or procedure on the plaintiff's health. So that's a very succinct and hopefully valuable couple of slides for you to keep in the back of your mind when you're developing a consent for telemedicine treatment, but also keep in mind that if you are starting a medication or a treatment or asking the patient to undergo a procedure that you are still responsible for, such as a diagnostic test, you need to go ahead and ensure that you're covering those bases as well. So next we'll talk about the assessment of appropriateness for telemedicine.
Thanks, Julie. So after the physician has obtained the patient's informed consent to the telemedicine encounter, the physician next must assess whether the complaint that the patient presents is appropriate for telemedicine care. To do that, a physician must have appropriate medical records or be able to obtain information during the telemedicine encounter that's adequate to treat the patient. All pertinent data and information needs to be available from the telemedicine encounter, and the technology used must be entered into the medical record and documented. Next is whether or not the physician can form an opinion about treating the patient. Does the physician have enough information to provide that, to form that opinion? If not, the physician, as the physician would in any in-person encounter, needs to advise the patient that he or she just simply does not have enough information to provide treatment, and direct the patient for an in-person visit or request additional data, or perhaps refer the patient to a specific type of specialty. Certainly during this particular season we're in with the COVID-19 pandemic and its recommended social distancing, telemedicine provides a very good option for both our physicians and our patient population to provide needed care to patients in a safe manner. However, just because the option is available does not mean that it's appropriate for the patient. And it is as important to make that determination, and when necessary, to make that determination that it is not appropriate. Sometimes that's just the best way to treat our patients.
And so next, we're going to look at the scope of practice and the standard of care as it applies to telemedicine. It's essential that providers continue to meet standards of care when delivering care by telemedicine and to comply with laws and regulations in the treatment of their patients. Even during this extraordinary time, there's nothing virtual about virtual medicine. You are providing health care to patients. And one of the biggest risks of telemedicine is the lack of knowledge of standard of care, specifically where the patient is. So for example, in Tennessee, we follow the locality rule. We talked about that earlier when we looked at the statute for medical malpractice cases in Tennessee. And that's essentially the community standard. So you have to be familiar with what the standard of care is in the community where the patient is at the time of the encounter. It's not necessarily the community where you are, but it's where the patient is at the time of the encounter. And as I said, that's actually provided for by statute in Tennessee. So if I'm sitting in my home or office in Tennessee, I have to be familiar with the local standard of care for the patient sitting in Tennessee, whether that patient is sitting in a rural community, which may have a different standard of care than a patient who's sitting in Nashville. And that's probably the biggest risk when you're talking about liability risk, the potential for being required to build a case in another jurisdiction. Again, it's not necessarily the jurisdiction that you are in when you're providing telemedicine care, but it's the jurisdiction in which the patient is located at the time of the encounter. Of course, before undertaking telemedicine outside of your medical professional liability coverage area, you should check to be sure that you have coverage to treat patients in other states. Telemedicine is not something to dabble in or to take casually. If you're brand new to telemedicine and you're starting to see patients remotely because of the COVID-19 pandemic, please be thoughtful in this process and take a little time to determine what's available to help you get started. That could mean contacting your EHR vendor. The current focus has been on the immediate need to treat patients with minimal contact and exposure to potential infection. The relaxation in a number of federal and state rules, and even the more accessible virtual technology allowable during COVID-19, may encourage physicians to take advantage of the benefits of telemedicine. But that doesn't mean that this is a casual situation, and you need to treat the patient just like you would in your office. Keep in mind that there are commercial products with advanced technology platforms incorporating algorithms and systems to serve as a safety net for virtual care. That doesn't mean that you can't provide the standard of care via telemedicine. And so we're going to take a look at some of the typical telemedicine services in the next slide. A look at the typical telemedicine services highlights one of the benefits of telemedicine, and that is quick access to medical care to treat routine, usually minor conditions that keep people out of work, school, or other activities. Without treatment, often these minor illnesses can develop into more complex and costly problems. And so telemedicine is allowing people to get back to work and to get on with their lives, often without leaving their homes or workspace. And on the screen, you see some typical common ailments that have been seen and treated through telemedicine prior to the COVID-19 pandemic. And so our next slide is going to talk about telemedicine during this pandemic. It's important to know that the standard of care for the telemedicine encounter is based on the state where the patient is located. In almost every jurisdiction, at least that we're aware of, the treatment is going to be considered provided in that jurisdiction where the patient is sitting at the time of the visit. That is sometimes known as the originating site or the spoke site, and so you may hear those terms as well. If it's deemed to be telemedicine in another state's law, then that physician is likely to be held to the same standard of care as an in-person visit. That being said, the current COVID-19 pandemic has resulted in states of emergency, leading to executive orders relaxing or suspending regulations to allow more open access to healthcare. For example, in Tennessee, Governor Lee suspended, to the extent necessary, to give the Commissioner of Health the discretion to allow a healthcare professional who is licensed in another state and who would otherwise be subject to the licensing requirements to engage in the practice of such individual's profession in Tennessee if the individual is a healthcare professional who is assisting in the medical response to COVID-19, including treating routine or other medical conditions. Those physicians allowed to temporarily practice in Tennessee are permitted to engage in telemedicine services. Likewise, 47 states have modified in-state licensure requirements for telemedicine in response to COVID-19, paving the way for physicians to practice medicine in other states. It's still strongly recommended that before engaging in telemedicine in another state, that you contact that state's medical board as well as your medical professional liability carrier. Now, when it comes to nurse practitioner and physician assistant supervision suspension, remember that if you're in a collaborative agreement with an advanced practice practitioner, you should be aware of partial suspension of rules, including an order suspending the collaboration or supervising requirements until May 18th. Now, our interpretation of the order is that it was intended to suspend the requirement of collaborative agreements in order to allow for the access to care specifically related to the COVID-19 crisis. While it could be interpreted to be broader than this limited scope, we would suggest caution in applying it in a broader context. Further, while working together in a collaborative agreement, we recommend, that you make it clear that your relationship may be terminated if the practitioner no longer wishes to have you review records or collaborate on his or her care. If it is a practitioner within your own practice, our recommendation would be that you continue your established arrangement unless suspension is necessitated to address the current crisis. Executive orders allow nurse practitioners and physician assistants to write orders for home health services as necessary to respond to and prevent the spread of COVID-19. Now, as far as HHS relaxed technology requirements, some attempted video visits, unfortunately, have had to be switched to the telephone or to less HIPAA-compliant platforms such as FaceTime and Skype. And while neither of those platforms is compliant with privacy regulations, HHS has recently declared that it will not enforce compliant rules in this time of crisis, while telehealth is provided in good faith. Likewise, if you're using public-facing remote communication products that have been identified as unacceptable, including group chat, you'll want to remember about these HHS relaxed technology requirements. And basically, that's any product that does not require a username or password on both ends to be you. So don't use that if it's open to the public. That's not going to be considered good faith. And so the OCR is expecting providers to use private and non-public facing remote communication products that by default only allow the two parties to participate. So be sure to keep remote communication devices locked. Now, Julie's going to talk a little bit about documentation.
I know you've heard it many times before, but documentation may be the most important defense tool if your care is later challenged, and that includes telemedicine. Documentation needs to be the same as an in-person visit, but obviously, given the nature of the remote visit, there may need to be some additional considerations there. So if something comes up in the future and the care is challenged, there's no question that this was, one, a telemedicine encounter, and the standard of care was followed by every clinical situation. There may be potential problems if you're seeing patients and not properly documenting those visits. Not just medical professional liability, but you could also have a reimbursement problem if you have an audit and you're billing for that without an adequate record. Possibly worse, if you have a liability question, how are you going to defend it if there's no contemporaneous record of the complaint and your assessment and plan? So it's just not good medicine if you're not documenting each patient encounter as you would for the in-person visit, We realize that's a challenge in a number of ways because many of you aren't using a virtual platform and you don't have an electronic health record to assist you with completing that documentation. But you can look at this as any other documentation that you would with any other encounter. One of the hurdles of the traditional physical exam can be overcome with an appropriate virtual examination. I've spoken with a lot of physicians recently, and one of whom said, you know, in her experience, 80 to 90% of the assessment of a patient is gleaned from listening to the patient and asking the appropriate questions and sort of funneling down and drilling down to what the patient's real complaints are and what the appropriate examination would consist of. So you may have some opportunity out there with your resources on your specialty society or association websites. There are many that are available according to your specialty or your patient population to assist you with an exam that works virtually and that gets you to the appropriate diagnosis. For example, there are a lot of orthopedic maneuvers that you can ask the patient to perform while you're watching. You can ask the patient to count to 30 while they're breathing in, and you observe that, and that may give you some information that may be helpful in your examination. Keep in mind also, you should continue to document your differential diagnoses, just as you would in the office. There are some states that have telemedicine specific documentation requirements. For instance, Tennessee requires that you state what type of technology is being used, and if you're using synchronous audiovisual, are you using other means as well? Make a note that it was adequate to assess and treat the patient's complaint. Make a note on how you used the technology to adequately assess and treat. And of course, if it's not adequate, we've mentioned this many times before, abandon that telemedicine call and give that patient a direction as to where to go. A benefit to telemedicine is that the platform used may give you that advantage of having the timestamp. So if the physician had a 15 or 17 or 21-minute session with this patient, that will help demonstrate a level of care. But be sure you don't leave the details undocumented because you think the telemedicine encounter speaks for itself in some way. It does require the same level of documentation. And if you determine, again, if telehealth is not appropriate, document that you referred the patient for an in-person visit. That may be to you or that may be to a consultant. Document where, to whom, and what timeline they should be seen. I know a lot of patients are afraid of contracting COVID-19 with an in-person visit, but you can do your best to educate them about COVID-19 and what steps are being provided in your office or in an emergency department or a clinic that can help relieve their anxiety about that. Document that referral for necessary testing or consultation as well. All that being said, I certainly don't want to leave you thinking that you can't do an appropriate examination through telemedicine. Of course you can. And a recent study in 2016 that United Healthcare did based on their emergency department claim volumes, where emergency visits were low acuity and could be treated in a virtual visit. They found that a number of those, at least 25% of their claims from an emergency room involved conditions that could appropriately be addressed with a virtual visit. So that's something to consider. Just identify those and make sure that you document why that was appropriate to be a virtual visit. So next we'll talk about medical records, as they are another important part of your telemedicine liability considerations.
And Julie, I think you're right. Documentation of any care, whether telemedicine or in person, is going to be of crucial importance if in a year or later from now our physician is facing a lawsuit or a claim. And certainly in the setting of a telemedicine encounter, especially lately, our physicians are going to be likely outside of their normal routine, habit, or practice. They're not in the office following their standard procedures of documentation. I think we're all outside of our normal routine, habit, or practice lately. So it's very important to consider the documentation and how you're going to document and how you're going to create your medical record. Consider it before you begin your visit and prepare for it in advance. Some of the more unique considerations with respect to a telemedicine visit, and certainly with respect to a telemedicine visit these days, might be, where is the physician storing the information, like physically keeping it in the encounter. Certainly there is as we mentioned earlier, not only requirements for privacy under federal regulations, under HIPAA, but there's a state requirement of privacy and of confidentiality. You also want to consider how to preserve the integrity of the information. If the medical record is somehow temporarily created and is going to be more formally created in a later date, you want to make sure that the information you've recorded is accurate and is reliable and is factual. Another thing to consider would be, what is the document retention period for this certain record that is involved? Certainly Tennessee has specific document retention periods depending on the patient. Is the patient a minor? Is the patient an adult? And also for different classifications of records. At the bottom of our list, we reference multi-state considerations. As Jay discussed earlier, the location of the care is going to be generally the location of the patient. So if you have a patient who is not located in Tennessee, but the care, and thus the care is not occurring in Tennessee, it's occurring in another state, then that state may have different medical record retention requirements. And we need to be aware of that. Other issues to consider are, how is the physician going to get access to information from the visit in advance or subsequent to the visit? Also, how will the patient get access to the visit, get access to the information after the visit? And importantly, how does the MPL insurer or payer get access to the information in the event of a claim or an audit? So one specific question our company has been getting recently with respect to medical records and documentation during the COVID-19 crisis is on your screen, is shown on your screen. Should I place a statement in the medical record that treatment was provided during the COVID-19 crisis? And the answer is no. We do not recommend creating a separate statement in the medical record that the treatment was provided during this time. We've seen some of these statements that include waiver language, attempting to waive liability or outlining a list of deficiencies with the care that is provided during these circumstances. Such a statement may not shield a physician from liability for substandard or unnecessary care. It's important to understand that liability exposure will not be waived by a statement of the challenges of providing care during this unprecedented time. Keep in mind, the decision to provide care and offer treatment may expose a physician to liability even in the midst of COVID-19 if the unnecessary treatment is determined to be below the standard of care, or if unnecessary treatment or treatment without consent is provided to the patient, even if the treatment was within the standard of care. If the unfortunate and unanticipated thing happens, which is a lawsuit is subsequently filed, the fact that the care at issue occurred during the period of the COVID-19 crisis Whether, frankly, the care was provided virtually or was provided in person will be one of the many factors that a jury considers in adjudicating the case. The COVID-19 crisis is such a monumental event in our nation's life that it is certainly going to be a part of the common knowledge of any juror who is alive and an adult, or perhaps even was a child during the time of this situation. So there's no need to document such a common knowledge. And frankly, doing so may have some negative ramifications that the physician doesn't anticipate. A jury may ask, why did the physician need to document that the care was provided during COVID-19? In other words, they may ask, was this substandard care? Would the care have been better had it not been provided at a different time? So it can hurt you, frankly, more than it can help you. And moreover, it's important to know that, frankly, from a legal perspective, it's not effective to waive prospective liability. And on the issue of liability and lawsuits, of course, that goes hand in hand with insurance. And Julie is going to talk a little bit more about telemedicine liability coverage.
Thanks, Katie. Yes, first I want to clarify that my answer will be with respect to how SVMIC is providing coverage. And if for some reason you have coverage with another provider, you want to reach out to that particular provider and ensure that you're covered as well. SVMIC is more than happy to work with physicians to provide telemedicine coverage, and we have seen a huge uptick in successful telemedicine practice just in the last month. We know treating patients during the COVID-19 pandemic requires innovation and flexibility, and our physicians have certainly stepped up to the plate. We simply ask that you call us to discuss the details so we can make sure that you and your policy are fully equipped to respond as needed for your particular situation. But keep in mind that, rest assured, there are currently no changes necessary for adding telemedicine to your policy under the following circumstances, which you'll see on your screen here. Generally, if you're practicing within the scope of your licensure, you're following the telemedicine guidelines, if any, of your state medical board, which we do have telemedicine guidelines in Tennessee at the Board of Medical Examiners. You're providing care to an established patient, or you're establishing a relationship with a new patient who resides within the state in which coverage has already been agreed upon by SVMIC. So that's a little bit murky. So if you are going to provide telemedicine to new patients outside of Tennessee, we do ask that you contact our underwriting department. You may want to look at the Federation of State Medical Boards, which can be found at fsmb.org, as they are keeping a great daily update practically of all of the states of emergency for the various states that you may be considering practicing in. You also want to ensure that you're providing care, if you're providing care to an established patient in another state, maybe they are going somewhere else, or they're in college, or they're having to take care of a relative. Coverage may be provided for your established patients in that other state, but again, be sure and call SVMIC or your medical professional liability carrier just to be sure that you don't have any type of licensure issue. We do know that most states, including Tennessee, have suspended or relaxed their full licensure requirement, but that may or may not give you automatic coverage for your medical professional liability in that state. So again, if you're practicing in Tennessee, you're generally covered. Just give us a call if you are planning to practice and see patients outside of the state.
And so in summary, here are some key considerations when practicing telemedicine. Contact the medical board in every state where you plan to treat patients. Review the board regulations for every state where the patient is located. Contact your medical professional liability carrier about coverage for telemedicine. And note that if a claim arises, you will likely be sued in the state where the patient is located and would have to defend it there. Be sure you are comfortable with the standard of care for the visit. You can adequately address the patient's complaints, adequate exam, develop a diagnosis, recommendations, follow-up plan, and other aspects. There could be a coverage issue if the care violates licensing rules and regulations, and that may be an exclusion from coverage. Contact the patient's healthcare insurance carrier and ensure that they will pay for the visit. If the carrier won't, then that might red flag a bigger concern with the visit. It's important to address that with the patient up front and avoid a surprise to them and hopefully limit problems with the patient paying later. Address the practice of telemedicine with your own group and employer to ensure that telemedicine is allowed. The group may already have policies and procedures that should be followed to avoid a defense issue if care is challenged. It's important to remember that the telemedicine visit should be within the physician's scope of practice. That is, a diagnosis, consultation, treatment, follow-up, and other aspects. Both the physician and the patient must utilize adequately sophisticated technology to enable the remote physician to verify the patient's identity and location with an appropriate level of confidence. Even with relaxed HIPAA technology requirements, remember the physician-patient conversations are confidential. It is the provider's responsibility to discuss the question of confidentiality and identify who is in the room with the patient as well as the provider. Obtain consent from the patient to treat them by telemedicine. This conversation may be documented as written or verbal, depending on state requirements. A simple consent form or verbal conversation should suffice. A macro may be developed to assist and document any consent discussion. Document thoroughly. Pay attention to an appropriate examination, clinical judgment, and differential diagnosis. Your documentation should support the care provided and follow-up discussion. And finally, telemedicine is not appropriate for all conditions. Refer patients for in-person treatment when indicated. Don't attempt to practice medicine via telemedicine if diagnostic testing or consultation with a specialist would be required at an in-person visit, unless you can accommodate those needs. And so in closing, we want to thank you for attending this webinar. A copy of these materials and other resources, including a link to obtain CME credit for this course, can be found on the Telemedicine Education Series launch page on the TMA website. You see the link there at the bottom of this slide. We'll give you just a few seconds to write that down if you need to. Again, thank you for attending this webinar. And on behalf of Julie and Katie and myself, we want to thank you for all of the services that you're providing to your patients and to your community.